because mine was a little different. I did make some changes, so if I miss out on anything, please do add, yeah. So starting with the physiology and anatomy of pancreas. So pancreas is a long, slender organ, and most part of this is located posterior to the bottom half of the stomach. It is primarily an exocrine gland, which means that it releases hormones. It also secretes, no, it's a exocrine gland, which means that it secretes digestive enzymes. I'm sorry. It also secretes hormones such as insulin and glucagon. And the pancreatic islets, these are the cluster of cells that, as you can see here, the alpha beta. So they secrete the hormones glucagon, insulin, and it also secretes somatostatin and pancreatic polypeptide. So the last two hormones are secreted in very small amounts. Therefore, we mostly study glucagon and insulin. So the endocrine function involves, as I said, secretion of insulin and glucagon, and it's produced by the alpha and beta cells. The alpha produces glucagon and the beta produces insulin. There's also something known as delta cell, which accounts for about 4% of the pancreatic islet cells, and these produce the hormone somatostatin, which is involved in again the regulation of pancreas, regulation of insulin and glucagon. The polypeptide cell, it produces the pancreatic polypeptide hormone, and it is thought to play a role in appetite. So again, because it's produced in very less amounts, we don't usually study about it a lot. So our body, as we know, right, that our body loves homeostasis, and if homeostasis is not maintained, the body immediately reacts to get it back. So here we can see the normal function of the pancreas. So on your left, when on your top left, when the sugar level is about 160, which is high, it's hyperglycemia, then the insulin release through the beta cell is initiated, and that is taken to the splenic artery. Splenic artery is the artery that supplies blood to the pancreas. So because it's a hormone, it's released directly into the bloodstream. The effects of insulin are that it triggers body cells to take up the extra glucose floating in the blood and use it either in producing ATP or store it as fat. It also inhibits gluconeogenesis, which is production of glucose by the liver. Insulin also stops the smooth and the smooth ER to stop producing glucose and not convert the free fatty acids into glucose. And the bottom right, on the bottom left, as we can see, the blood glucose is 50, which is hypoglycemia. That is when the alpha cells are triggered to release glucagon, and the effects of glucagon it includes the opposite of insulin. So it will stop the body cells from taking up glucose. It will stimulate gluconeogenesis and also stimulate the breakdown of fat and produce fatty acids. So basically, every method in which the blood can increase the glucose level is triggered by glucagon. Am I clear so far?
Yeah.
Yes.
So this happens in the normal situation in every person, actually, without diabetes or with diabetes. So now we'll move into discussing diabetes. So it is characterized by either a complete lack of insulin, a relative lack of insulin, so less production of insulin, or insulin resistance. And this again these defects result in inability to properly use glucose for energy. So initially we discussed the effects of insulin and how the body utilizes it and what effects insulin has on the body. So when there's a complete lack or resistance, then the body's sugar levels are going to go haywire, because then the body is not able to use glucose for energy. So do you guys know the normal value of glucose, the normal range?
I think for fasting is 4 to 7,
Mm-hmm.
and non-fasting is 9 to 12.
Yeah. So this is, you're talking in the other unit, right? M mole per,
Yeah, yeah, yeah.
yeah. So yes, as you said, the normal levels are what you mentioned. Because I studied in the States, I normally remember the values in ml, in the mg plus and mg by deciliter. So the normal values would be less than 100, the fasting. If a person is pre-diabetic, it would be between 100 and 125. And again, if a person is diabetic and who's not on any medication, the fasting blood glucose will be above 126. So that's above 7. And the A1C values are given as well. And also the oral glucose tolerance test. So all these three can be performed to diagnose a person with diabetes. However, the fasting blood glucose and the A1C are preferred, because the oral glucose tolerance test is, it gives you a lot of data, and then you have to analyze that data. So these are just easier methods to diagnose a person with diabetes. However, one should never be diagnosed based upon just one reading. It should be done at least twice, and it should be done for both the fasting blood glucose and A1C. So in terms of classification, there are three, but two of them are very major. So type 1 and type 2 diabetes, and the third one is gestational, which is mostly transient. In terms of type 1 diabetes, it consists of 10% of the diabetic population, and type 2 is it comprises majority of the type of the diabetic patients. Type 1, it is characterized by lack of endogenous insulin. So the beta cells that produce insulin are damaged. It's usually it's autoimmune, so it's destroyed by the person's own immune system. However, some type 1 diabetics are also idiopathic, so we don't know what causes it. It's not an immune response, but it yet happens. In terms of type 2, it is characterized by insulin resistance and insulin deficiency. So it's manifested first by insulin resistance, and later on there is insulin deficiency. So a type 1 diabetic patient will present typically with an earlier onset. So the person is young. They're usually malnourished and thin because since the patient is not producing any insulin, the body starts breaking down the person's proteins and fat to produce glucose and provide energy. And the three P's, which is polyuria, so a lot of urination, usually during the nighttime. Polydipsia, there's a lot of, the person is very thirsty since they're losing uh, all the volume. And polyphagia, so it means that they're very hungry. So these three are, along with weight loss, these three are also present in a type 1 diabetic. Again, some most of the time, because type 1 diabetes is, it manifests earlier in life, the patients present with diabetic ketoacidosis. So in this case, we'll discuss this later on in this presentation, but The two main things are blood glucose is above 300, and the patient has fruity breath. It's because of the acetones that are produced by ketone breakdown. And for treatment, insulin is required. Type 2 diabetes, patients present, so it happens late and it's a gradual onset, usually above the age of 35, and the patient presents with obesity. And this is as a result of insulin resistance. So disease progression is like there is insulin resistance first, which causes the pancreas to make more insulin because the pancreas thinks that there's less insulin, so I need to produce more as a compensatory method. And hence the pancreas overcompensates and eventually fails. So as I said before, insulin resistance happens first and then insulin deficiency happens in type 2 diabetes. Again, with symptoms, the three P's. Along with that, there's blurry vision, there's dry skin, there's also sexual dysfunction. And these are different than type 1 diabetes because these happen because type 2 diabetes manifests gradually. So there is nerve damage, there's vessel damage, and that's why there are more complications here. And in this case, patients may present with another situation called HHS, so hyperosmolar hyperglycemic state. We will also discuss this later. In this, there are no ketones present, but the blood glucose is double the amount that we discussed earlier, and there is severe dehydration. So, do you have any questions about type 1 and type 2? Did I miss out anything that you want to add? Am I clear so far?
Yeah.
Okay. So again, the easiest way to differentiate between type 1 and type 2 is by measuring the okay. By measuring C peptide levels. And so
For
type 1,
type 1,
sorry. Yes, you were saying something. Okay, let me continue. So by measuring the C peptide levels, so C peptides are a precursor of insulin. So type 1 diabetes, because the body does not produce any insulin, the C peptide levels would be less than 1 nanogram per milliliters. Whereas type 2 diabetic patients will always produce some amount of insulin. So the values will be greater than 1 nanogram per ml. So now moving on to gestational diabetes. This is mostly transient. It happens because of glucose intolerance, which is first recognized during pregnancy. It's usually during the third trimester. And this happens because of hormonal changes during pregnancy, which result in insulin resistance. Most women return back to a normal state. However, it does increase the chance of developing type 2 diabetes later in life. So the hormones that cause the insulin resistance are mentioned here: growth hormones, cortisol, estrogen, progesterone. There's some hormones produced by the placenta, such as the lactogen and insulinase. So since in gestational diabetes, the sugar levels are high, the baby is getting more energy than it needs to grow and develop, and therefore the extra energy is stored as fat. So a mother with GD will usually give birth to a fat baby. And this also is that it's harmful for the babies because the extra insulin that's made by the baby's pancreas to overcompensate for the high blood glucose in the baby then results in newborns having low glucose levels at birth. and they might have breathing problems, and also they're at a risk of obesity. So that was it for gestational diabetes. Treatment we'll discuss later. So before we move into details discussing other things, let's discuss the physiological effects of insulin. So insulin is synthesized as a prohormone, which is called proinsulin. In the liver, insulin increases the storage of glucose as glycogen, as we discussed before. Skeletal muscles, then it results in stimulation of glycogen synthesis and protein synthesis in the skeletal muscles. Adipose tissue, insulin facilitates triglyceride storage by activating plasma, lipoprotein lipase, increasing glucose transport um, into the cells by GLUT4 transporters. So this is all under normal circumstances, not in a patient with diabetes. So here's a image that shows that insulin, when it's released when high blood glucose is detected in the blood, and therefore when insulin is released, it will work on different tissues to reduce the blood glucose. So liver will start storing, muscles will also start storing, and also the adipose tissues as well. And glucagon does just the opposite. Uh, so what happens when there is insulin deficiency? So this entire thing goes out of normal, out of homeostasis. And this then causes impaired glucose metabolism. There's also impaired lipid and protein metabolism. So how is glucose metabolism affected? So deficiency of insulin will cause the liver not to utilize glucose properly. Then it will, as insulin stimulates glucose uptake in different tissues such as adipose and skeletal, um, it will also be reduced, and so throughout the body, basically there will be less uptake of glucose by all the different tissues. So the tissues will not be able to take glucose, not produce energy, and there will be less energy throughout the body. So the patient will start feeling fatigued. In terms of lipid metabolism, insulin does not affect directly the lipid levels, but it stimulates the hepatocytes to synthesize triglycerides and then store them in the adipose tissues in normal circumstance. In uncontrolled type 1, which has no insulin release, it leads to rapid mobilization of triglycerides. So the body does not have any does not have any method of uptaking glucose because of lack of insulin. So the body will start using triglycerides, and there will be increased levels of plasma free fatty acids. These high levels of fatty acids then reduce the utilization of glucose, because fatty acids are easier to use than glucose. So again, this adds up to hyperglycemia, which is already present in the patients. And again, what we discussed, ketoacidosis. So free fatty acids, when these are used as an energy resource, there's a byproduct of ketone bodies, which leads to ketoacidosis. And so this is spontaneous breakdown of ketone bodies into acetone, and which results in the fruity breath. So regarding protein metabolism, insulin increases the rate of protein synthesis and decreases the rate of protein degradation. So insulin deficiency will do just the opposite. There will be less of protein synthesis and more of protein degradation. This is when there's an absolute lack of insulin. So usually the reason why type 1 diabetics are they have a low weight is because insulin deficiency leads to catabolism of protein. So before we move on to epidemiology, do you guys want to add anything to what I just discussed, or this is fine?
I think we're good.
Okay. So regarding epidemiology, the global prevalence in 2019 was 9.3%, and again, it's estimated to rise to 10.2% by 2030. So this is huge, and these are just patients who are diagnosed. There are many patients who go undiagnosed because high blood sugars, they a lot of people are asymptomatic, especially if it's type 2 diabetes. They just think that um, it's probably transient, and they a lot of people have barriers to getting tested. And type 2 and type 1 both, especially type 2, it's a major cause of blindness, kidney failure, heart attacks, stroke, and also lower limb amputation. Again, it's because it's very gradual. A lot of people are not able to understand that it's happening to them. And as I said, prevalence is increasing rapidly in middle and low income countries. Again, these are just some data. Okay, in terms of pathophysiology, as we know, the body's main source of energy is glucose. Cells metabolize glucose through glycolysis and the Krebs cycle, which produces water and carbon dioxide as byproducts. Glucose, which is not needed for energy, is stored in the liver as glycogen, and insulin stimulates that. And later on, when the glucose levels are very low, for example, overnight, when we don't eat anything, our glucose drops. So that's when glucagon is released and gluconeogenesis is stimulated by that. Again, these are the same things that we discussed before. The effects of insulin. Yeah. Mm. Yes. So as I said before, right, that patients with type 2, they most of the all these things, right, like thirst or urination, eat like hunger, these are not very a lot of people are not aware that these three are main symptoms of diabetes. So at the time of diagnosis, most patients have already lost 90% of beta cell function, and the remaining uh, remaining 10%, they at diagnosis, it creates a honeymoon period during which blood glucose levels are easier to control and smaller amounts of insulin are required. So once this remaining beta cell function is also lost, then the person becomes completely insulin deficient, and it requires more of exogenous insulin. So during the honeymoon period, it is easier to manage by just the oral medications. But again, there is no way that the 10% beta cell function will be preserved. Over time, a patient might lose that as well. And as I said before, during periods of fasting, especially such as overnight, glucose is produced by the liver as by gluconeogenesis. And these are just things that we already know of. So the first phase, insulin response, it usually lasts during 10 minutes and serves to suppress hepatic glucose production. This is when the blood is when the pancreas detects a lot of glucose in the blood, so that the first bolus of insulin then minimizes hyperglycemia during meals and during the postprandial period. The loss of this first phase insulin response is an early event in the progression from glucose intolerance to diabetes to DM. So basically, what it means is that patients with diabetes, before they become diabetic, there is a period where the pancreas is not producing the initial insulin response. So it happens gradually. So first it will First it was probably producing like 100% of insulin, then it starts producing less and less. And when the patient presents to the clinic, they have probably completely lost the first phase insulin response. So they have high blood sugars immediately after meals. The second phase is a gradual increase in insulin secretion, which stimulates the uptake over a period of time. And this is a more slower insulin, which allows the body to respond to new glucose entering. So, what the first phase is similar to, it's the bolus one. So, you know, the mealtime insulin that we give people, especially type 1 diabetics who, you know, who have zero insulin production. And the second phase refers to the basal insulin, so which is there in the body throughout the day, and it's slowly letting the tissues take up glucose, and it maintains glucose levels at a certain interval, 70 to 100. The hyperinsulinemia, or high blood levels of insulin, is an early finding in the development of type 2 diabetes. This is because, as I said before, that the pancreas is trying to overcompensate, thinking that the body is not getting enough insulin, but not knowing that there is actually insulin resistance, sorry. Again, as type 2 diabetes progresses, large number of patients with type 2 disease will eventually lose all beta cell function. So the main thing to remember is that in type 1, it happens very quickly, and in type 2 it happens gradually, but eventually most of the diabetic patients end up requiring exogenous insulin, sorry. And again, insulin resistance, it may be present up to 10 years prior to diagnosis. Okay, let's move on to, yeah, these are just, okay, another thing to remember is insulin has a half-life of 3 to 5 minutes because it's a free monomer. So moving on to etiology, as we already touched upon it a little, it's selective destruction of pancreatic beta cell by the T lymphocytes. So it's autoimmune, and it can also be idiopathic. So most of it is autoimmune, but some of it can also present as idiopathic. These are the risk factors for type 2 diabetes. In adults, again, in both actually, overweight, there's lack of physical activity, family history is a big one. And you know, such clinical conditions associated with insulin resistance, uh, C, uh, such as the PCOD, even hypertension is a risk factor, dyslipidemia is a risk factor. So usually hypertension, diabetes, dyslipidemia, they are these three things that a lot of patients have together. So one increases the risk factor of another. uh, in terms of clinical manifestation, symptoms are similar, but they will vary in intensity. As I said before, type 1 it's more severe and faster in onset. And these symptoms we discussed before, the three P's: polyuria, polydipsia, and polyphagia. There's also fatigue. Weight loss is mostly in type 1 patients, and blood vision is mostly in type 2 patients. So this is just like what characteristics play a bigger role in type 1 and type 2. Okay, so
Excuse me.
sorry.
Did you mention that the neuronal regulation of insulin?
The what?
The neuronal regulation of insulin,
The normal.
like where the neuronal
Okay, like where the
alpha 2 receptors, they activate decrease insulin release, and beta 2 stimulate increase insulin release, and acetylcholine and vagal stimulation cause insulin secretion.
no, I did not mention that. Thank you.
Yeah, I added on that to that.
Okay, can you just repeat it so that everyone can hear?
Alpha 2 receptor activates decrease insulin release by
Mhm.
inhibiting beta cells, and beta 2 stimulates increase insulin resistance by stimulating beta cells, and then acetylcholine and vagal stimulation causes insulin secretion.
Okay, thank you. Is there anything else that anyone wants to add? Okay, let me just continue then. So in terms of screening recommendations, currently the ADA recommends routine screening for type 2 diabetes every 3 years in all patients who are above the age of 45. Um, and testing for type 2 should also be considered regardless of age if a person has higher BMI and also have other risk factors of diabetes such as family history, hypertension, dyslipidemia, PCOD, and things like that. For gestational diabetes, the screening should be for everyone at the first prenatal visit, and especially for patients who have high risk factors. And it should also be for everyone using the OGTT, so the oral glucose tolerant test between 24 and 28 weeks of gestation. The diagnosis criteria for diabetes is this is for type 2. For type 1, screening recommendations are not recommended because it happens early on in the life. So there's no really, it doesn't make sense to screen them because also the population is very small. So in this case, fasting plasma glucose should be greater than 7 or 126. The 2-hour postprandial plasma glucose should be more than 200. A1C should be more than 6.5, and random plasma glucose should be more than 200, along with symptoms of the diabetes, the 3 Ps. For gestational diabetes, there are two strategies that exist for screening. The first one is one step, 2-hour 75-gram oral glucose tolerant test, which is more preferred because it finishes in one day. And there's a two-step process which includes a 1 hour. So in the first one, the 2-hour 75-gram, the pregnant woman would come in. She would consume 75 grams of glucose, and again she would be fasting. It should be done in at when the person is fasting, and every hour the reading will be taken. So the person comes, takes up the 75-gram glucose, then after 1 hour the reading will be taken, after 2 hours another reading will be taken, after so it happens just in one day. In the two-step process, which includes a 1 hour 50-gram non-fasting screening, so the person doesn't have to fast, and this then is followed by a 3-hour 100-gram oral glucose tolerant test. for the patients whose 1 hour reading is greater than 140. So this usually takes a longer duration than the first one. So as I said before, the fasting glucose will be taken. Then the person takes up the 75 gram of glucose. Then at 1 hour, a reading is taken, and second hour, another reading is taken. And the diagnosis will be when the following values will be exceeded. So fasting, if it's greater than 90, 1 hour, if it's greater than 180 or 10, and 2 hours if it's greater than 153 or 8.5. So as I said, the two-step process is longer and you have more readings here. So the first one is usually preferred. So in terms of preventing diabetes, body maintaining like weight loss is very important. Being physically active, eating healthy diet, avoiding sugars. So these are all non-pharmacological ways of preventing diabetes. And smoking cessation is also very important. Uh, in terms of goals of therapy, the ADA recommends the glucose levels to be between the fasting should be between 70 and 130, and the postprandial should be less than 180. And this is a more detailed version of goals of therapy. So A1C should be less than 7. The postprandial 80 and 130. Peak postprandial should be less than 180. So the peak after meal, so peak postprandial, which is 2 hours after. So we usually prefer this one, the peak postprandial. Again, all these blood pressure recommendations should be less than 140/90. Lipids, again, it should be in normal levels. So as we mentioned before, non-pharmacological ways of preventing, it's also the same as managing the diabetes. So again, diet should be low in fat, high in fiber, low in carbohydrates. Weight reduction, the patient should include regular physical activity to not only improve the glucose control, but also manage their hypertension or reduce the risk of developing hypertension. So before we move on to treatment, if there is anything you guys want to add, since I studied, we studied in different places, I don't know what you people exactly covered. So if I'm missing out on anything, please let me know.
You're doing great, Doctor. Just yeah, it's the same content.
Okay. Okay, so in terms of treatment of type 1, insulin. So that's the only one that is used widely in type 1 patients. And usually the patient use between 0.6 to 1 unit per kg per day, which gives us starting dose of 0.5 units per kg per day. So this has to be titrated very quickly because it depends on the patient, right? And most of the patients have a continuous so they have a pump attached to them, and they have a continuous release of insulin. So the pump outside, it usually acts like the pancreas inside. So it will give a bolus insulin, it will give a basal insulin, and things like that. Yes, so insulin are basal and bolus. Most formulations are available in unit 100, which then the concentration is 100 unit per ml. Insulin, once the vial is open, it's good for 28 days at room temperature. and it's administered subcutaneously using a syringe or a pen device. Pen device is more popular right now. So before we move into this, let's talk about the different injection sites. So there's upper arm, there's abdomen, there's buttocks, upper outer thighs. Mostly people prefer the abdomen, the upper outer arms, and the upper outer thighs. Buttocks are usually, like, I don't know anyone who uses buttocks for insulin injection. So it's very important to rotate injection sites, because if you're pricking at the same site, there will be lipohypertrophy, so there will be a fat buildup, and it will then hinder the absorption of insulin. It's also important to also point out that absorption rate is varied among the injection sites. The abdomen has the highest absorption rate, versus the buttocks have the least absorption rate, and therefore abdomen is the preferred site. And it's also easier to change the injection site, because you can then rotate around your belly button. So classification: bolus, it's usually rapid acting or short acting. Short acting is basically the regular insulin which our body produces. Basal insulin is intermediate acting and long acting insulin. Insulin is destroyed in the GI tract, and therefore it must be given subcutaneously or IV. So therefore we do not have any oral formulation of insulin. It's also inactivated in the liver and kidney. So as we said before, its half-life is usually 3 to 4 minutes. Not sources of insulin, it's cow. It's slightly more antigenic. It's because it's a different mammal that we're using it from. So nowadays we don't use the beef insulin. Human insulins it's produced by recombinant DNA technologies by inserting the human proinsulin gene into the E. coli or yeast, and then these microorganisms are treated, and they extract. So they basically start producing insulin from the gene that was inserted into them. Human insulin from E. coli is available for clinical use as humulin and dispensed as either the NPH, Lante, or the ultra Lante humulin. Rapid acting insulins include, so these are basically short acting insulins, right? The regular, the NPH, Lente, and ultra Lente. Rapid acting ones are the insulin aspart, Lispro, and glucilin, glulicin. They have rapid onset of about 15 to 30 minutes and very short duration of 1 to 2 hours. These are also known as mealtime insulin, because they are being given directly before the insulin. So this basically imitates the first phase insulin release that we discussed before, right? The 10-minute boost in insulin release. So this mimics the pancreas like that. And these are usually used with a longer acting insulin, so which is the basal insulin, to assure proper glucose control. And these are administered subcutaneously 15 minutes prior a meal. Regular insulin, it's unmodified crystalline insulin, commonly referred to as natural or human insulin. It is a clear solution and has a relatively short onset and also short duration of action. Again, it's the purpose of regular insulin is the same as rapid acting insulin. It should be given 30 minutes before a meal, and it also mimics the first phase insulin release. And this is the only insulin that can be administered IV. So regular insulin is soluble crystalline zinc solution. Onset of action is 30 to 45 minutes. Duration of action is about 5 hours, and it can be safely used in pregnancy. And this is also used in the intravenous therapy in the management of diabetic ketoacidosis, which we'll cover later in this presentation. Intermediate acting insulin. So this one is isophane insulin. It's a suspension of crystalline zinc insulin combined with the neutral pH, the protamine H-dorn with protamine. It's positively charged peptide. So basically what happens here is that the regular insulin is combined with protamine, which is a positively charged peptide, and this causes the duration of action to be intermediate and not so adding another functional group to insulin will decrease the rate of metabolism of it by the liver and therefore increasing its half-life. And this is due to delayed absorption. So this since it's a positively charged peptide, it will be so what okay, let me put this like this, right? So if it was a lipophilic compound, right, without any charge, it will be absorbed very quickly into the bloodstream. But since isophane is positively charged, it will be absorbed slowly through the subcutaneous layer into the bloodstream and therefore increasing its half-life. And since it's a charged compound, and the purpose of it being charged so that it is absorbed slowly, it should only be used subcutaneously. It should never be given intravenously. It is useful in treating all forms of diabetes except, as I said, right, where intravenous treatment is needed in diabetic ketoacidosis or emergency hyperglycemia. It is designed to cover insulin requirements in between meals and overnight. So this is used as a basal insulin. So since we have longer acting insulins, the intermediate ones are not really used that much since their duration of action is less than 24 hours. You need multiple insulin shots. And since protamine is a foreign body, it can increase the risk of allergic reaction. So these are actually, so in the rapid acting insulin, the aspart, Lispro, and long acting insulin, the glargine and detamir, these are more commonly used these days. The glargine and detamir are designed as once daily dosing of basal insulin, which provides a constant insulin concentration over 24 hours. Insulin glargine differs from the regular insulin by 3 amino acids, resulting in a low solubility and at a physiologic pH. Which makes it slower in onset than the intermediate insulin. It has a prolonged hypoglycemic effect and must be given subcutaneously. The ultra-lente insulin which is a suspension of zinc insulin crystal in acetate buffer. This produces large particles that are slow to dissolve. Wait. I have a quick question. So ultralante is different from detamir, right?
Yeah, it's different.
Okay, because they have not mentioned detamir here.
I think, yeah, it's been mentioned in this one slide.
This one. No. Okay. Okay, so ultralente insulin, suspension of zinc insulin crystal in acetate buffer. This produces large particles. So since it's attached to a crystal, it will it will produce large particles, and large particles will obviously be slow to dissolve, and therefore it results in a slow onset of action. So it uses both the insulins use different methods of increasing their half-life. Insulin glargine, it is different in 3 amino acids, which results in low solubility. So it will dissolve slowly because of its chemistry, and the ultralante insulin will dissolve slowly because it is a large particle. So depending on the particle size, so they both are long acting, but they use different methods of increasing their half-life. And this is just a summary table of onset, the peak, and also the duration of action. Regarding insulin storage, all insulin should not in use should be stored in refrigerator. If it is not possible, then it should be kept away from direct sunlight and sources of heat, because it will lose its potency. And when insulin is in use, it can be stored at room temperature for 28 days. Starting dose of insulin in type 1 and type 2. So in type 1, it's high. It will be higher. So anywhere between 0.2 to 1 unit per kg per day. And in type 2, it should be anywhere between 0.2 to 0.3 unit per kg per day. Again, this is not one size fits all. The starting dose of insulin is entirely dependent on the patient. So this just gives us a starting point, but some people might require more and some people might require less. Regarding adverse effects of insulin therapy, so hypoglycemia is a big one because insulin directly affects the glucose levels. And this is therefore the most common complication of insulin therapy. And a lot of patients need to be educated on this, knowing the signs of hypoglycemia. This results from inadequate carbohydrate consumption. So, when patients are diabetic and on insulin, they start thinking that, oh, I should not consume carbohydrate at all because my diabetes has progressed to a level of insulin. So when they are on insulin, they'll start consuming less of rice, less of chapati, and things like that. Again, there might be unusual physical exertion and too large dose of insulin. And all cases of hypoglycemia are relieved by glucose administration. So insulin allergy, which is actually a very rare condition, can also lead to complications of insulin. But this is normally very rare. Lipodystrophy at injection sites. So as we said before, right, if a person is not rotating their injection site, there is a hypertrophy of the subcutaneous layer, and therefore it hinders the insulin absorption. Insulin, as it's used in type 1 diabetes, it is also used in gestational diabetes. This is the only safe medication in GD. Some oral glucose lowering agents are not recommended because they don't have long-term safety data. However, metformin and glyburide, it may be used off-label, but both of them close the placenta. So the first one to manage should be insulin. If And most of the cases, insulin does resolve the gestational diabetes. So patients might never have to take metformin or glyburide. So regarding the type 2 diabetes, oral agents, so now where the pharmacology comes in, right? So the oral agents are currently that are available are mostly indicated for type 2 diabetes who are unable to maintain their glucose levels through diet and exercise. So before we move into detail treatment and the oral agents, is there anything that you want to add or anything that I did not mention so far? Or if you have any questions. Sorry, I never asked if you have any questions.
I don't have a question, but I was suggesting we take a 8-minute break until 11:15. Then
Okay.
from 11:15, we can now, especially with the oral anti-diabetics, I think we can now engage the audience and ask for the mechanism of action, side effects, especially just from the slide you've displayed, where, yeah, we should be able to summarize the treatment of diabetes. From this slide, we'll mention all those stuff. So 11:15, let's come back. This slide will remain displayed throughout the break. Just pick a class of drug, just do a slight overview, a 5-minute review, come back, tell us something.
Yes.
Yeah.
Before that, can we just talk about the insulin receptor, the insulin signaling, so that we mention each and every receptor, and it will be easy for us to know the hypoglycemic agents and the MOA.
Yeah. I was even thinking we didn't mention how insulin is released. We say they are released from beta cells, but yeah, the mechanism of action of release of insulin. Yeah, we can do that. Yeah, we can do that. We can do that.
Try that. I can try that, and correct me if I'm wrong or I missed something. Okay, guys.
Yeah, we have Dr. Waweru here. He'll correct you.
Okay. In glucose, it actually enters the beta cells by facilitated transport, and then it's phosphorylated to glucose 6 phosphate by glucokinase. And then the glucose 6 phosphate is used to generate ATP. Then when it's generating ATP, so you know ATP is changed to ADP, and then inhibiting ATP synthase will lead to a potassium channel, like hypermembrane potential will change. So the level of potassium will decrease, there will be more potassium efflux, and then causing a resting potential that's higher. And then when the resting potential is higher, it will lead to opening of voltage sensitive calcium channel, which will also depolarize the beta cells. So when we are at that scenario, when the beta cells are depolarized, the intracellular calcium will cause activation of phospholipase A2 and protein C, and the levels of IP3 will rise. As we know, IP3 is an intracellular messenger, which will also facilitate additional release of calcium into the cytosol. So the intracellular concentration of calcium acts as an insulin. It acts like an insulin mediating agent that actually causes the secretory cells or vesicles to promote insulin secretion, more of insulin secretion from us. Yeah, that's what I know so far. Anyone can add anything else.
Nice. Thanks, Shafi. Anyone else with something to add on that? I'll summarize that entire process also. Okay. If there's no one, 11 now. Still 8 minutes break. 11:20. We are coming back. All of this oral anti-diabetics. Everyone must talk. Yeah. You'll tell us, anyone can say something on the mechanism of action, side effects, instructions to give to patients, or anything you can mention about these classes displayed here. 11:20. Just first, I'd like to highlight, okay, has written on the chat board that the insulin secretor GOGs, they lower blood glucose by stimulating secretion of insulin in the body, hence increasing insulin levels in the blood. Side effects, one is weight gain, and two is hypoglycemia. So anyone else with something to say on any of this class of anti-diabetics displayed, or any other class that you may know of that is not displayed here?
Hey guys, good morning. Hello.
Willie, we can hear you.
Oh, I'm audible. So, let's talk about biguanides, such as metformin and metformin ER. And what they do is they lower the postprandial and the basal glucose. And they do this by reducing the hepatic glucose production and reducing intestinal absorption of glucose. And then after that, they also improve the insulin sensitivity by increasing peripheral glucose uptake and utilization. I also share the side effect.
Pardon?
They also cause, as for like the common side effects are usually vomiting, the normal nausea, diarrhea, and then it may also cause a chest discomfort. Also, people usually get bloating due to this metformin as a common adverse effect. And they may also cause chest pains or chest discomfort. So, patients who have cardiac failure are contraindicated from taking biguanide.
Patients who are?
Patients who have cardiac failure are contraindicated. Yani, it's contraindicated in them.
Biguanides, kina metformin.
Yeah. That's
not different class.
The thiazolidinediones.
Yeah.
So
Yeah. So
Okay.
Willie has talked about mechanism of action of metformin, the common side effects. Anyone else with something to add on metformin or biguanide?
Metformin is associated with inaitwaje, imenitoa kwa kichwa, alkalosis, ni acidosis ama ni
Lactic acid.
Nice, yeah, lactic acidosis. Anything else? Anything else? Patient advice. Any other contraindication of metformin?
Itraconazole, fluconazole, I think also erythromycin. I'm not sure about that. They're contraindicated with metformin because they inhibit the CYP3 enzymes, and then they lead to prolonged risk of hypoglycemia.
Lead to prolonged risk of hypoglycemia.
Another one would be alcohol.
Alcohol, yeah.
Yeah, lactic acidosis. So using them together, you will have an added ongeza to the lactic acidosis. Yeah, metformin.
Yeah, nice interaction with alcohol. Lactic acidosis will occur, so you advise patients. Yeah.
Also, CYP enzyme induces like barbiturates, carbamazepine. They decrease the glucose by lowering. They decrease the circulating glucose, I think, because the enzyme induces, right? Am I right, guys? I'm asking you.
I don't know. And, even for the other interaction, I'm assuming it's something you're sure of. No matter you're telling us.
I know they decrease the glucose because when they're combined with biguanides, but I don't know how they decrease that. And examples are barbiturates, carbamazepine, also rifampin.
Okay, that's another interaction. Anything else to add on biguanides?
I don't know if it was talked about the vitamin B12 absorption. Was it talked about?
No.
Oh yeah, so metformin is notorious for causing deficiency of vitamin B12. So patients who are taking metformin should advised to go and test for vitamin B12 testing levels because it depletes vitamin B12.
Yeah, nice. Then Shafi, for the interaction between metformin and the azole antifungals, according to Medscape, there is no significant interaction. The two are not contraindicated to be co-administered. Perhaps you can share your reference that said they are contraindicated.
Really, that's not biguanides, it's magletides, the insulin secretagogues ones. Whatever that I was mentioning. Sorry. Yeah.
Okay, that makes more sense. Yeah, because the biguanides, they rarely cause hypoglycemia. Patient advice. No one has mentioned, we've mentioned alcohol. Any other advice? Are they to take them with meals, without meals, or it doesn't matter?
You give it with meal to decrease the GI discomfort.
Yeah, nice. Give it with meals to decrease the GI discomfort. Yeah, great. Yeah, another class. Let me see. People who have not unmuted. Waweru, Corazon,
Niseme
Laila.
alpha glucosidase inhibitors. An example is, of course, acarbose. MOX, the delay absorption of carbohydrates. So in this case, they'll reduce the postprandial blood glucose. So the effects, because of now they act on the GI, the side effects, they include the GI disturbances. So yeah.
Yeah, nice. And how are they administered? How will you tell the patient to take acarbose?
Acarbose ni ukiteka a bite of meal ndo na meza.
Yeah, nice. With the first bite of the meal, they take the acarbose or the any other alpha glucosidase inhibitors apart from acarbose.
Miglyton.
Pardon?
Miglyton.
Yeah. The third one.
Voglibose, I think.
Yeah, voglibose. Another class. Let me see. Dr. Sam from Kabarak, Mystique, Saru, Sonia. You haven't unmuted. Can't tell me you don't know anything about diabetes.
I can just share the mechanism of action for DPP4. For DPP4 inhibitors. So basically, basically some examples of DPP4 is sitagliptin, saxagliptin. There are quite a number. And they work by inhibiting the breakdown of the incretin peptide hormones. So there are two main incretin peptide hormones, which are implicated in this basically in diabetes. So it's GLP-1 and GIP. So yeah, so they are gut hormones. So okay, GLP-1 is glucagon like peptide 1, and GIP is gastric inhibitory polypeptide. Those are the two major incretins, and the two primary incretin hormones which are secreted from the epithelium, the intestine, upon ingestion of glucose or nutrients, so that they stimulate the insulin secretion from the beta cells of the pancreas. So basically, DPP4 is an enzyme, dipeptidyl peptidase-4 enzyme. And once it's inhibited by these DPP4 inhibitors, it prolongs the actions of these incretins that we've just mentioned, the GLP-1 and the GIP, and this enhances now the insulin response. Oh, sorry about that. So yeah, and this causes this improves the glycemic control. Yeah, so a common preparation I think that we've probably seen in the market is Yamet, which is a combination of metformin and yeah, it's very commonly used for control or as part of the regimens for oral anti-diabetics. And I think I've seen also, when I was searching, I've seen this DPP4 inhibitors is one of the safest oral anti-diabetics. It doesn't have a very wide side effect portfolio, if I can call it that, and it has several advantages. Sometimes it's also used as monotherapy, as a part of therapy for people who have just been diagnosed with diabetes, and it's very safely coupled with metformin, like Viamet. Yes, not very significant unless somebody has seen any, not many significant drug interactions. So it's safely given with antihypertensives, antihyperlipidemics, because most times the people of diabetes have other comorbidities, so they are on other medications as well. Yes, it also has a cardiac friendly profile. Yeah, so it's a relatively safe and efficacious oral antidiabetic. Yes.
Nice. Thank you so much. Thank you so much. I think she's summarized DPP4 inhibitor. She's given us the examples. Yeah, one of the safest antidiabetics out there, usually combined with metformin, can even be given as a first line on its own. Yeah. Aya. Another person. Hata kama ni example, sema. Mistake.
Okay, so I feel that question. Emma?
Pardon?
I'll ask afterwards.
Mistake. Go on. She said she's asked when she'll ask when she's done.
I'll say for the sodium glucose transporter inhibitors, examples are like canagliflozin, empagliflozin, I think it's bexagliflozin. Basically, these drugs work by inhibiting the sodium glucose transporters that are found in the proximal tubules.
Proximal convoluted, yeah.
Also, they prevent the reuptake of sodium and glucose, and that leads to more excretion of glucose. This drug will be used also in patients in cardiac heart failure, with or without type 2 diabetes. The common side effect is candidiasis or UTI is common those infections due to the presence of glucose in urine.
Okay, nice.
I don't know what else to say. Yeah, that's it.
Yeah, that's great. SGLT2 inhibitors, yeah. She's given us the examples, the canagliflozin, yeah. They have that suffix gliflozin, yeah. It inhibits glucose absorption in the proximal convoluted tubule. Remember when we were talking about the diuretics, we mentioned the SGLT2 transporters. She said it increases excretion of glucose in urine. So if there is more glucose in urine, we know the normal flora that is usually there, it will now utilize that glucose. Hence, we'll see more cases of candidiasis, more cases of UTIs. Yeah. And because they also have kind of a diuretic function, there's a possibility of hypotension. So if this patient is still being given some antihypertensive drugs, at least for the first week, second week, you need to monitor the blood pressure. She's also mentioned recently they have been seen to have a really good effect on heart failure, that it can be given to heart failure patients even without diabetes. They can just be given to heart failure patients because of that mild diuretic effect, among other effects. Anything else? I think no one has talked about no one has mentioned examples of sulfonylureas, the meglitinids. We haven't talked about them really that much, and also the thiazolidinediones. Yeah.
Okay, I'll talk about the thiazolidinediones. Examples, you have pioglitazone, rosglitazone, trioglitazones, and One thing about these drugs is that they're used in diabetes, especially the one associated with insulin resistance, because they have a mechanism in they play a role in decreasing the insulin resistance. So in case the patient presents with diabetes mellitus and it's associated with insulin resistant, this is the preferred medication, maybe an add-on or monotherapy. And another thing about these drugs is that they have major side effects. Actually, there was a time that they were almost suspended, being that pioglitazone is majorly was associated with bladder tumors. Rosiglitazone was associated with cardiovascular disorders, and pioglitazone was associated with hepatitis. So they are very risky drugs. So, okay, their mechanism of action being that they are insulin sensitizers, they increase sensitivity of the target organs to insulin, and they also decrease insulin resistance. Their side effects, we have, they cause fractures in women, especially in women, that's osteoporosis. They cause fluid retention, edema, so they're contraindicated in congestive heart disease. They also cause weight gain. Yeah, they cause weight gain, but better thing about them is that they don't cause hypoglycemia. Yeah, they also, I think, contraindicated in breastfeeding and lactation and pregnancy. Yeah.
Nice. What about, do they have anything, given they have that name Thaya? Do you know anything about their sulfur, if a patient has sulfur sensitivity or allergic to sulfur, does it have any effect?
Yeah, I think, yeah, thiazolidines and sulfonylureas, they have that sulfur moiety.
Yeah, nice. So I need to watch out for that. I'm seeing Lila as an add-on to the mechanism of action of the thiazolidinediones, that they activate the PPAR gamma, hence decreasing insulin resistance. The PPAR gamma, also known as the peroxisome proliferator activated receptor gamma. Once you activate that receptor, you increase insulin sensitivity. Yeah. Otherwise, yeah, she's mentioned it all. The side effects, the fluid retention, the edema, hence for people with heart failure, we will not give them these drugs, right? She's also talked about the weight gain, because of course, when we see a drug as fluid retention, we're expecting there'll be some weight gain. The increased incidence of osteoporosis, risk of bladder cancer. I don't know if anyone who's either currently working or for those of us who went to attachment, if they have ever even seen any of these thiazolidinediones. Personally, I've never, but I don't know if anyone has ever seen them in their practice. Anyway,
I think
next.
the only one that I've seen in used is the pioglitazone.
Pioglitazone in Kenya or in the United States?
In Kenya, in India, actually. In United
in-
States, the thiazolidinediones are rarely used.
Okay.
Guys,
Yeah.
I also want to add the PPAR receptors. They are more likely to found in fatty tissues. So that's the major side of thiazolidones.
Yeah, nice. Yeah, they're more likely to be found in the fatty tissues. Now sulfonylureas examples. I think someone mentioned their mechanism of action in the chat box, but no one has talked about examples, and also there's usually something unique about sulfonylureas. Some are short acting, some are long acting. So with administration, we'll see some differences.
I can talk about it.
Okay.
So it's divided into two generations, the first and second. The first one includes examples such as the tolbutamide, which is short acting, and the second generation ones are the glyburide, the glipizide, glimepiride. So the second generation is actually more popular in use. So the mechanism of action, I think it's mentioned, but I'll still go through it. So these actually work by opening the potassium channels in the beta cells that someone mentioned, the whole secretion of insulin. So the opening of potassium channel will then cause the hyperpolarization, which will lead to the opening of calcium channels, and then ultimately stimulating the release of insulin. These have high.
Doc, you've mentioned, does it open the potassium channels or does it close it, leading to depolarization? Is depolarization our target or hyperpolarization?
Hyperpolarization.
Because Shafi
Actually block the
Shafi
air.
mentioned,
Yes.
It's the opposite. We close the potassium channel, potassium accumulates inside the cell, depolarizes the cell, then calcium gets in.
Yes. I'm sorry. I got confused. Yeah.
No worries.
Yes, so it will lead to the closing of potassium channel, which will lead to depolarization, and then calcium will enter, causing the insulin release.
Yeah, nice. And side effects, do you wanna mention any that the two that were mentioned were hypoglycemia and weight gain? Maybe anything else perhaps you wanna add on?
No, the two most common ones are hypoglycemia and weight gain. And again, because it has a sulfur moiety, we have to be careful with people having sulfur allergy.
Yeah, nice. And now also Shafi had mentioned this, that these sulfonylureas, they are majorly metabolized by now the CYP system. So of course we will be expecting a lot of interaction with the potent CYP inducers, the potent CYP inhibitors. Yeah. Some is mentioning that they also promote insulin sensitivity in other tissues and organs the main mechanism of action is promoting insulin release, but they do have glucose sensitizing action as a minor function. Yeah. The other thing, of course, the sulfur sensitivity is you have to take care when you're giving to patients with glucose 6-phosphate dehydrogenase deficiency. The risk of hemolytic anemia will be there. Shafi?
There was disulfiram reaction with alcohol.
Yeah. That's another thing. Yeah, disulfiram like reaction with alcohol.
So that reaction lead to flushing, flushings and all the symptoms.
Yeah, flashing, vomiting, headache, all those things that Chai was experiencing on Sunday morning. Yeah, he can tell us more about that. Then, yeah, the second generations are the ones which are more used. Yeah, perhaps on the field, personally, I saw glimepiride is a really common one. Perhaps someone can mention another sulfonylurea they saw being used commonly, because these are the ones that are tested, the ones that are used commonly. Okay. Finally, the meglitinids. Someone here is saying meglitinids. Who hasn't talked? Sarafina Saru. Samiha. Nightwing. Something on meglitinids. And Sam, by the way, wewe ndio daktari wetu hapa na uongei.
So, meglitinids. So basically, they work to reduce the blood glucose levels by stimulating the endogenous insulin production. Examples will be something like repaglinide and metiglinide. Yeah. What else can I say? They have said they work to reduce blood sugar by stimulating endogenous insulin production. By endogenous insulin production, I mean is like they will induce insulin secretion from the pancreas. Okay.
Nice. Anything else?
No, I think that's all I know.
Okay, nice. In the style of harambes, nani akona kitu ya kusindikiza the points Saru has nini? The points Saru has mentioned, nani atamsindikiza? Laila has mentioned that they are used in sulfur allergies, because now these ones do not contain that sulfur moiety, and they do not cause weight gain. This one's majorly you just see them causing the hypoglycemia. Nice.
Just want to add that these are more selective for the potassium channels, and they're used in lower doses than sulfonylureas. And again, because they have the same mechanism of action, they should not be used together.
Yeah, they share the exact same mechanism with sulfonylurea, so you shouldn't co-administer. Laila is also mentioning that these drugs will not work if a patient is having severe hyperglycemia. Perhaps something else I know about these drugs is that they are really short-acting, so they should be taken only if the patient is eating. They're typically taken 15 to 30 minutes before a meal. So, but if the patient is not eating, they are not to take the meglitinids. Samiha mentioning that unlike the sulfonylureas, that these drugs have a more rapid onset of action. Yeah, that's true. These ones, they are really short acting, really short acting, right? When we come majorly to the second generation sulfonylureas, which are the ones majorly in use, you'll see they are given perhaps even just once a day, right? Because they have that delayed onset, they work throughout the day. Dr. Bansri, back to you. Perhaps now, as you go through the remaining slides, you'll just highlight the things that have not been mentioned. Perhaps what are the first line medications? When do we give one drug? When do we give two drugs? When do we give three drugs? Such things. But otherwise, I think on the drugs, we've exhausted.
Okay. So starting with the sulfonylureas, here we've mostly covered everything, just that the second generations are more potent and they're longer acting than the first one. So they're usually used more. We rarely see the first one. We mostly don't see the first ones in use. We've also mentioned the mechanism of action, that they block the potassium channel and increase the calcium intake, and therefore stimulating insulin release. So one thing that we did not mention is that it's well absorbed orally. It's metabolized by the liver and excreted by the liver or kidney. I think we've mentioned all this, that it's contraindicated in pregnancy. Yes, that's it. Yeah, so sulfonylureas are not recommended in patients who have renal disease. And monotherapy with these agents will produce a decline of A1C by 1.5 to 2%, which is actually a very good one.
Let me ask, why sulfonylurea is not recommended for people with kidney problems?
Let me.
You guys have heard my question. Okay.
Yes, I heard.
Perhaps if you can go to the previous slide. Yeah. You see, they enjoy
because they're excreted through the kidney. That's why. And most of them have active metabolites. So if the kidney function is reduced, there will be accumulation of these drugs. Therefore, it should not be used in patients having renal impairment. This is what I can recall from what I've studied. But if you have anything else, you can add.
I think it's that if you have liver kidney impairment, the sulfonylurea will build up in your blood and the active metabolites will build up, so hypoglycemia.
I mean, it was mentioned in this slide that it should be used in caution because it will lead to accumulation of the drug and cause hypoglycemia. I think here we have mentioned mostly everything. Yeah. Again, it's metabolized by the CYP enzyme and excreted through the bile. So this will also have drug interaction. Yeah, we've mentioned all that. Lower blood. Yeah, so metformin, what we did not mention is that it's the preferred initial pharmacologic agent, which is used for the treatment of type 2 diabetes. Exact mechanism is not really known. And this also has shown to reduce the A1C levels by 1.5 to 2%. It does not affect insulin release, and therefore hypoglycemia is not common with metformin. It's usually well tolerated. Metformin also loses weight, which is mostly because of loss of appetite. So weight loss, sulfonylureas cause weight gain and metformin causes weight loss. And metformin is excreted through the kidneys, and therefore patients with kidney impairment, which is EGFR of, if it's between 30 and 44, it should be used in caution. And if there is severe kidney disease, like end stage renal disease, then metformin should be avoided in those patients. A starting dose is usually 500 milligrams twice daily. And maximum recommended dose would be around 2,500 milligrams daily. It should be, yes, as I said, it should be completely avoided in patients with EGFR of less than 30. That's usually when patients are in end stage renal disease. We've mentioned the common side effects, like GI related. And it can be, as we said, it should be given with a meal, and it can also be minimized through slow titration of dose. Yes, interference with vitamin B12 absorption has also been reported. So patients should be supplemented with B12 tablets or injection. And yes, we've also mentioned the chance of lactic acidosis. However, it is rare. It is recommended as a second-line alternative for patients who fail or have contraindications to metformin therapy. It also has a good HbA1c reduction of 1.5. And we've mentioned the mechanism of action, that it increases insulin sensitivity. One thing we did not mention was that it has a delayed onset of action, usually several weeks, and may require up to 12 weeks before maximum effects are observed. And mostly that's the reason these drugs are not very common. And yeah, side effects, we've said hepatotoxicity, it does cause weight gain, unlike metformin. So with the alpha glucosidase inhibitors, it's the reason it has high GI side effects is that it's rarely absorbed into the bloodstream because it is very polar. And mostly we have mentioned everything. It reduces the, it delays the absorption of carbohydrates into the bloodstream. And because it has high GI side effects, these drugs are also rarely used. I don't remember if we mentioned this, but we might have, but I forgot that SGLT2 inhibitors, they cause recurrent UTI. And if a patient reports urinary tract infections, then usually these drugs need to be stopped if it's recurrent, because diabetic patients already are at a high risk of infections. And if you're using this drug, the glucose in the urine then also increases the risk of infection. So again, these drugs are very safe to use, but if a patient complains of recurrent UTI, then it needs to be re-evaluated. So GLP-1 receptor agonists and DPP-4 inhibitors. So these two drugs, they have similar similar targets, but they work in a different way. So their end result is the same, but they have different mechanism of action. So when somebody takes food, the intestine secretes GLP-1, which is an incretin, in response to the food, which then goes to the GLP-1 receptors, activates it, and again that decreases appetite. It goes to the pancreas and stimulates the production of insulin in the pancreas and suppresses glucagon secretion. And in stomach, the GLP-1 receptor activation causes slower gastric emptying. And so the two drugs, GLP-1 receptor agonist, the GLP-1 receptor agonist directly stimulates the GLP-1 receptors, and the DPP-4 inhibitors. So DPP-4 is an enzyme that degrades natural GLP-1. So the DPP-4 enzyme inhibitor will inhibit the enzyme and therefore increase the endogenous GLP-1, which then will activate the receptors. So GLP-1 receptor agonists and DPP-4 inhibitors again should not be co-administered together because they have the same drug targets. We've talked about these. Yeah, I think we've mentioned pretty much everything from here. Yeah, the adverse effects are headache and nasopharyngitis. I don't know why nasopharyngitis is a side. If anyone knows, they can talk about it. It is a side effect, but
Stanley, I don't know if Stanley can talk about that. I remember him mentioning something about DPP-4 inhibitors. By inhibiting this DPP-4 enzyme, there is something that is not broken down. Like the same way we were mentioning about ACE inhibitors, there is something that is not broken down, leading to that nasopharyngitis. Stanley, I don't know. I've ever heard him talk about it. I don't remember what exactly it was.
okay. Okay, I can go to that. I mean, I'll read about it and I'll message on the group why it causes nasopharyngitis.
Okay.
And all these all these acute pancreatitis, hemorrhagic and necrotizing pancreatitis, these have been reported, but again, these are very rare. Hypoglycemia is not a common side effect because it does not have anything to do with insulin secretion. Okay, no, sorry. It does increase insulin secretion, but again, it is through the GLP-1 activation, which is because of the meal that someone is taking. So it is food regulated insulin release, not random insulin release that is caused by drugs like sulfonylureas. So the GLP-1 receptor agonist, we talked about the mechanism of action, that it directly stimulates the GLP-1 receptors. Its effects are that it reduces post-meal glucagon secretion, as we said, increases satiety, which then decreases food intake. And because of these reasons, again, GLP-1 receptor agonist and DPP-4 inhibitors also cause weight loss, especially the GLP-1 receptor agonists. They cause weight loss. These do not directly cause hypoglycemia, but if they're co-administered with either insulin or sulfonylureas, then the hypoglycemia risk increases. Here, the main side effect is nausea, vomiting. So again, all GI related, and the patients have to be counseled on this because it does cause significant nausea, especially nausea. These are the these are the drugs, the liraglutide, pramlintide. Liraglutide I have seen is used extensively. So drugs are all discussed. If there is anything missing, you can add. I think we've pretty much.
Just maybe to take you back, what did you say about these ones on weight gain? On weight generally?
The GLP-1?
Yeah, GLP-1 agonist. Yeah.
You need to weight loss. They are also used for obesity, apart from just getting used in type 2 diabetes. Yeah.
Oh, yeah, nice. I've seen Nani has even tweeted about it. Thank you.
So insulin also comes into play when managing type 2 diabetes, but obviously not initially. Initially, we try with all the oral medications and the non-insulin injectables. But insulin is used when initially a patient presents with very severe hyperglycemia and are symptomatic. If they present in hyperglycemic emergency, if they have other medical conditions that require very tight glycemic control, such as acute myocardial infarction, stroke or sepsis. So usually, if any diabetic patient comes into the hospital with an MI, they're immediately, or a sepsis or stroke, their oral medications are stopped and they are then managed through insulin. If they have organ failure, if pregnant, if a person is pregnant, or if they have contraindications or failure to meet the glycemic control with oral medication. So when is it initiated? For type 1 diabetes, all patients are initiated. And in type 2, as we mentioned before, it is considered to be added to another agent if the patient does not have a good glycemic control or does not reach their A1C goal. Always the non-insulin injectables should be considered prior to initiating insulin therapy. If a person is already on a triple therapy, they should be monitored closely. And then And then if they still have sustained hyperglycemia, then insulin should be started. Again, when fasting, blood glucose is within goal, but the A1C remains elevated after 3 to 6 months, then a bolus mealtime insulin should be added. So as we said, unless any contraindication exists, metformin should be the preferred initial agent for type 2 diabetes management. If the A1C is between 6.5 and 7.5, metformin is preferred. But again, if the person's postprandial blood glucose is elevated, then a DPP4 inhibitor or GLP-1 receptor agonist can be added. Usually, monotherapy should be tried for 2 to 3 months. The reason metformin is preferred is because a lot of people don't always measure their postprandial blood glucose. Usually, the treatment is based on A1C, therefore metformin comes first. But if we have data available for the postprandial glucose, then the DPP4 or GLP-1 can be introduced. If on presentation their A1C is between 7.6 and 9, then dual therapy should be initiated. Again, metformin forms the backbone of the therapy unless it's contraindicated. Then either a GLP-1 receptor agonist, so any of the other pharmacological group, drug group can be used in combination with metformin. This dual therapy should be continued for 2 to 3 months, and then if still the A1C is, the goal is not met, then another agent can be added. If their A1C is above 9 and the patient is symptomatic, for example, they are severely dehydrated, they are in shock, then insulin with or without the additional oral agent should be given. If they're asymptomatic, then dual or triple therapy with metformin as the backbone. So metformin always forms the backbone, and all the other agents can be given based on the doctor's preference or the patient's preference. So the two important things to know is that once the metformin forms the backbone, and the patient has atherosclerotic cardiovascular disease, and they are also at a risk of heart failure, or heart failure already coexists, then SGLT2 inhibitors are preferred unless contraindicated. So a patient who has heart failure or has an ASCVD risk, then with metformin, your preferred agent should be the SGLT2 inhibitors and not the other ones, unless it's contraindicated. If it is contraindicated, then the second option would be GLP-1 receptor agonist. For patients with type 2 diabetes who also have chronic kidney disease, then either SGLT2 inhibitors or GLP-1 receptor agonist can be used. Usually, patients prefer the SGLT2 inhibitors because it's oral than an injectable. But they're both shown to reduce risk of chronic kidney disease progression. So here's the pictorial description of what we just discussed. Metformin, the first thing is healthy eating, weight control, and increased physical activity. All patients with diabetes have to attempt this, and even if they're on medication, they should be doing this. Metformin forms the backbone, and then based on and then the other drugs can be added. So the only two recommendations by the ADA is the heart failure patient should be on SGLT2 inhibitors, and the patients with CKD should be either on SGLT2 or GLP-1 receptor agonist. And insulin should be given when the patient is symptomatic and their A1C is above 9. Yeah, that's pretty much it. Here, so as we said before, metformin, initial pharmacological agent, and combination with insulin should be considered if also weight loss is a symptom and the fasting blood glucose is above 300. This is all just, yeah, it's also important to manage the concomitant conditions. So cardiovascular disease, all patients with a history of CV disease should be given aspirin or clopidogrel if aspirin is contraindicated. And antiplatelet therapy should also be considered in patients who are at risk of developing CV disease, such as if they have a family history or they are hypertensive. Statin therapy should be considered in all patients with diabetes. Hypertension goal, the ADA recommends the BP goal to be less than 140 over 90. And the ACE inhibitors or the ARBs are recommended at initial therapy because of their beneficial effects on the renal function. So we also mentioned before that patients with risk factors of diabetes are more likely to develop diabetes if they are, no, I don't think we mentioned this, if they're exposed to highly active anti-retroviral therapy, because glucose homeostasis disturbances are a known side effect of protease inhibitor therapy. So patients who are on these therapies should be monitored on their glucose. And metformin should be used in caution with caution in patients taking the nucleoside reverse transcriptase inhibitors, such as the stavudine, because of an increased risk of lactic acidosis. Antipsychotic drug therapy, there has been an association between second generation antipsychotics and the development of diabetes. The risks are highest between clozapine and olanzapine. No, the first generation antipsychotics, actually. There's a mistake here. So if a patient is using clozapine and olanzapine, it is recommended, if they have worsening glycemia, then it is recommended that they be switched to second generation antipsychotics such as risperidone. Yeah, so that was it for the concomitant conditions. If you guys have anything to add. I'm sorry, I'm just rushing through the slides because the time, it's almost 12:30.
No, it's fine. So anyone with anything to add on complications of DM before we finish with treatment of acute complications? Okay. I think yeah, we can finish strong, Dr.
Okay. So the three complications are hypoglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. So hypoglycemia, it's clinically defined as a blood sugar level of less than 70. And common causes are either delayed or inadequate food intake, especially carbohydrates, or if they have excessive doses of medications such as sulfonylureas and insulin. Or the patient is exercising when insulin is reaching its peak effect. The symptoms will include shakiness, sweating, fatigue, hunger, headaches, and confusion. Shakiness and hunger are the two major ones that patients can recognize quickly. So how do we treat it? Treatment involves 120 ml of orange juice, or 3 to 6, usually it's 3 to 6 glucose tablets, where every diabetic patient should be advised to keep glucose tablets in their reach, because they are at higher risk of hypoglycemia. So 3 to 6 glucose tablets. For patients with hypoglycemia, who have lost consciousness, intramuscular or subcutaneous, glucagon should be administered 1 milligram, and it may be repeated 15 minutes as needed. So it's very important to counsel the patient that they should be rolled over to their side, because glucagon injection induces vomiting in patients. So in terms of DKA, it is reversible but potentially life-threatening medical emergency. It results from relative or absolute deficiency in insulin. So this is more frequent in type 1 diabetic patients. So as we mentioned before, without insulin, the body cannot use glucose, and therefore they obtain their energy through lipolysis, or breaking down of fat. This breakdown of fat produces ketones, and then ketones break down and produce acetones, and then it leads to acidosis. And sometimes precipitating factors occur. Factors such as infection, omission, or inadequate administration of insulin leads to DKA. Infection, because when infection is present, then your body requires energy to fight infection, right? Therefore, your body is trying to gather energy from fat to fight off the infection, and ultimately then the patient goes into diabetic ketoacidosis. Signs and symptoms. So diabetic ketoacidosis develops rapidly over a few hours, and the telltale sign is the acetone breath, which smells like fruit. Again, this is combined with nausea, vomiting, and dehydration, and rapid breathing. Rapid breathing is because your lungs are trying to compensate for the low pH in your blood. The hallmark diagnostic criteria is hyperglycemia. The sugar level is above 250, and there is acidosis present, or the arterial blood pH is less than 7.3. Treatment goals are rehydrating the patient, reversing the metabolic abnormality, and normalizing serum glucose. So we would first confirm the diagnosis, then admit patient. So this is actually managed in a hospital setting. We would also assess the serum electrolytes, such as the potassium, especially the potassium, sodium, magnesium, the bicarb, phosphate, acid-base status. So all these monitoring should be done. Renal function. So the first thing would be to replace fluids, because the blood sugar is very high. It causes the osmolar pressure of the blood to be high, and therefore your cells are dehydrated. So you have to give several liters of normal saline as rapidly as possible to patients with signs of shock. So a patient might go into shock because of severe dehydration. And if the patient is not in shock, then they can be given 1.1 to 1.5 liter per hour of normal saline. So after the intravascular volume is restored, then we start giving the hypotonic saline. This is because your blood the osmolar pressure is very high, and therefore the water from your cells is being pulled into the blood. So if you give hypotonic saline, then the water will move back into the cells, which is concentrated. So isotonic saline is continued if the corrected serum sodium is reduced. So so once you give the patient 1 liter per hour of normal saline, then you evaluate them for sodium levels. So if the sodium is normal or elevated, then we start them on hypotonic. But if it is reduced, then we continue with giving them normal saline. Then we add dextrose to the saline solution when the serum glucose reaches 200. So the goal is to not rapidly decrease glucose level, but to rehydrate the patient and normalize their volume status. So diabetic ketoacidosis will cause a lot of electrolyte abnormalities. So once we corrected for sodium, then now we replete for potassium. So as it says here that regardless of initial measured serum potassium, patients with DKA will have total body sodium deficit. If the initial serum potassium is less than 3.3, we hold insulin and give potassium chloride. So if it's very less, the reason we correct for potassium before correcting for hyperglycemia is because low levels of potassium causes arrhythmias. So therefore we will first correct for potassium. And if once the level reaches till 3.3, and then we can start insulin. Again, these are all level wise, right? So but if the potassium is between 3.3 and 5.3, then we give potassium chloride 20 to 30 milliequivalent per liter IV. But again, if this is the case, then we can start insulin side by side. Yeah, these are just, I'll show you the table where it summarizes everything. So insulin is given to all patients with potassium level of 3.3, and either of the two regimens can be followed. 0.1 units per kg IV bolus, and then starting on IV infusion, or if patients are not being given a bolus, then we can start them on continuous IV with a little bit of higher rate of 0.14. So then again, every hour we will monitor for the glucose levels, and if it does not fall at least by 50 to 70, then we double the rate of insulin infusion. The goal is to reach glucose level of 200, and once that is reached, then the infusion can be slowed down a little. And it can also be, and once the pH level is normal and ketoacidosis is resolved, then subcutaneous insulin can be begun. When to give oral bicarb to patients? So this is when pH is below 6.9. It is not indicated. It is not indicated in mild to moderate forms of DKA because of metabolic acidosis, and it will correct. It will correct with insulin therapy. So once the pH is below 6.9, then we give 100 milliequivalent of sodium bicarb plus 20 equivalent of potassium chloride. And again, it may be repeated if the pH yet remains below 7. And this is the entire treatment algorithm. So we first start IV fluids regardless of what the of what the situation is. Then we assess IV fluids if it's severe, mild, or cardiogenic shock. If it's cardiogenic shock, then we give them pressors. If it's severe hypovolemia, we continue with 0.9 normal saline. Again, if it's mild hypovolemia, then we also correct for sodium levels. If it's high or normal, we switch down to 0.45% sodium chloride. If it's yet low, we then continue with the normal saline. We again check for potassium. If it's very low, we hold insulin and give potassium supplement. If it is between a normal, if it's below 5.3, we give potassium and also give insulin. If it's normal level, then we just keep monitoring for potassium. And insulin, as I mentioned, the only case you don't give insulin is when potassium is very low. Otherwise, we give them insulin. And bicarb is only given if the pH is less than 6.9. Hyperosmolar hyperglycemic state, it is a life-threatening condition similar to DKA, but this occurs mostly in older patients with type 2 diabetes. It lacks lipolysis, so basically there is no ketoacidosis here. In this case, the plasma glucose is above 600, so you can imagine the osmolarity of blood is very high, and therefore the patient is severely dehydrated. Treatment consists of aggressive rehydration and continuous IV infusion to normalize serum glucose, and correction of electrolyte imbalances, especially sodium and potassium. So in this case, for IV fluids, it's the same algorithm as for DKA. For insulin, the only change here is that we cannot switch to subcutaneous insulin. In this case, IV insulin is preferred. Otherwise, everything is the same. So in terms of long-term complications, so diabetic retinopathy is very common. This usually can be prevented by good glucose and blood pressure control, because then this will reduce the damage of the nerves inside the eyes. And patients should be checked for diabetic retinopathy every year. Yeah. Peripheral neuropathy is very common, and this can cause pain and tingling and numbness in their hands and feet. Two drugs that can manage this is pregabalin. Pregabalin is more commonly used than amitriptyline. And sometimes venlafaxine, valproate, and opioids can also be used if the pain is severe. Nephropathy is also very common, especially if the patient also has high blood pressure, because then it causes damage to the tiny blood vessels in the kidney. So early evidence can be seen by the presence of albumin in urine. So urine tests should be done annually. Yes, that's all. Again, for nephropathy as well, good glycemic and blood pressure control is essential in preventing this complication. And ACE inhibitors and ARBs should be used for BP management because they have nephroprotective property. Long-term complication, which is diabetic foot ulcer. Again, so this is an open sore that develops and penetrates into the subcutaneous tissue. The reason why diabetic foot ulcer happens is because uncontrolled diabetes causes nerve damage. And if you have a cut or a sore underneath in your foot, then the patient is not able to sense it, and therefore it leads to a trauma going unnoticed. and that's why it can cause infections and then ultimately leads to gangrene and leading to amputation. And again, the treatment, or not exactly treatment, but management should be glycemic control, again, preventing infection, checking your foot weekly to see if there is any cuts or bruises, then debriding the dead tissues, applying dressing, limiting ambulation if there is a cut, and the patient should wear properly fitted footwear and padded socks. That was it. I know the last portion was very quickly, but if you have any questions or if I missed out on anything, please add.
Nothing to add. Maybe, yeah, maybe if someone else has something to add, or yeah, because otherwise we are done with diabetes. Or any questions on diabetes, anything.